video is a shock management issue, and this is a question clinicians often ask each other. However, many of us do not know the appropriate answer to this question. However, shock per se is an abnormality of the circulatory system that results in an inadequate tissue oxygenation and organ perfusion. Management of shock is based on sound physiological principles. First of all, I am not going to go in all the details, but the key concepts over which shock management is based in is considering like all trauma patients having a hypovolemic shock, and by stopping bleeding and managing the blood loss with fluids and blood. Other types of shock like cardiac, pulmonary, neurogenic, septic are relatively uncommon. These shocks basically, as their name suggests, are found in their relative conditions and leading to a compromise. Their diagnosis is thought of either when the patient gives a history of injury or when the principles of hypovolemia correction are not able to correct the shock. The blood flowing in and out of the heart is based on the pressure gradients that are generated across like this is the common sense. Out of the blood present in the vessels, 70% of the volume contributed to the blood pressure, while the remaining 30% doesn't. Also, plus the Starling law that a rubber band recoils depending upon the limit to which it is stretched. Thus, if the blood within the system is less, the heart doesn't expand and thus doesn't give rise to a required cardiac output. Because of this, the first response is vasoconstriction in the skin and muscles and diversion of blood to the kidney, heart and brain. Tachycardia may thus be the first step to show up. On the other hand, catecholamines, vasoactive amines cause increase in the peripheral resistance, that is the diastolic pressure can can cause a decrease in the pulse pressure, that is difference between systolic and diastolic BP, and also there can be an increase in the vascular permeability and pooling of blood in the extravascular cellular third space. This also creates a condition called systemic inflammatory response syndrome, that is SIRS. Also at a cellular level, to sustain itself, it tries to generate ATP from glycolysis process instead of from the Krebs cycle, which is not an energy efficient manner. This leads to lactic acid accumulation which perpetuates cellular permeability, causing cell swelling and cell death. This condition is managed clinically with the help of oxygen support, fluid resuscitation and arresting hemorrhage if it is present. However, managing a shock condition along with the knowledge requiring clinical experience and also frequent reassessment hourly and daily till he fully recovers. Blood investigations of low hemoglobin and high lactic acid levels are indicative of shock. Hemorrhagic shock is diagnosed by a chest X-ray, a pelvis X-ray, a diagnostic peritoneal lavage or a fast exam. If it is a non-hemorrhagic shock, a cardiogenic shock is diagnosed by an ECG. If an MI or a cardiac tamponade, by the fast exam is diagnosed. A cardiac tamponade is managed temporarily by pericardiocentesis. However, an open thoracotomy may be required. A tension pneumothorax may be confused with a cardiac tamponade. However, it is differentiated by its absent breath sounds and tracheal deviation. This condition is treated by placing a needle in the second intercostal space mid-clavicular line. In the neurogenic shock, patient has bradycardia and hypotension because loss of sympathetic tone, and also there is history of spine trauma. Lastly, septic shock is sometimes an overdiagnosed condition, especially by our physician counterparts. However, the cause of it is when there is penetrating abdominal injury and contamination of peritoneal cavity with intestinal contents, or when there is a long-standing open orthopedic wound that has not been debrided, then it may occur probably. Hypovolemic management differs greatly with the patient's age. severity of injury, and pre-hospital fluid management. Time lapse of the presentation and previous medical conditions and medicines he takes. Whenever there is a volume or a blood loss, first the skin, the muscles and the organs compensate. Next the kidney gives way, and then the vital structures like the heart and the liver fall apart. Lastly, the brain is affected. Fluid loss correction needs to be tailor-made as per the situation one faces. In case of fractures like pelvis, liters of blood may occur, like 1.5 liter of blood when there is a shaft femur. In a shaft tibia or a humerus, there may be around 750 ml of blood loss. If the condition that I have described earlier, that is called the SIRS, is encountered, it may be managed accordingly. Even before the fluids and electrolytes are managed, airway actually takes a forefront. Also, measuring other vital signs, urinary output, level of consciousness is also important. CNS may get affected often in the setting of shock. Blood at the urethral meatus or high-riding non-palpable prostate is contraindication for FOLLEYS catheterization. For the fluid management, 2 large IV needles need to be taken, and most commonly antecubital veins are taken. If in any case these peripheral lines are difficult, then central lines are taken into consideration. Also, the sterility in the casualty setting is taken into consideration. The complications around associated like pneumothorax, hemothorax in an already compromised patient. The trend of using an intraosseous line may be novel at this moment, but it is rapidly coming in. The IV line, alternatively the blood ABG samples may be occasionally collected. If a central line is inserted, then central venous pressure is also monitored. The question often people ask me that which solution is used for an acute hypovolemic patient, or which fluid has to be used. Either normal saline or lactate may be used, as they cause transient expansion of vessels, also replace blood volume. Lactate is known to generate bicarbonate that counteracts metabolic acidosis. Second question I encounter following this resuscitation is like whether to transfuse packed cells or whole blood. Many trauma surgeons advocate whole blood in their patients as they give volume support. Also, what blood group to transfuse, whether O positive, O negative, auto transfusion, or the patient's blood group. Many advocate an O positive transfusion as it may not create a reaction. However, this practice should only be adopted when there are multiple patients coming in simultaneously with multiple organ failures and also with life-threatening conditions. O negative blood group is a relatively rare blood group. What protocol I follow is 2 liters of Ringer lactate with 2 IV running together with and occasionally a blood pressure cuff applied to a pint to increase the transfusion rate. If the patient vitals are responding sufficiently, and if there is a fracture diagnosed, and then 1 liter of packed cells of the patient's own blood group from the patient's very blood group that has been collected, that may be like auto transfusion during the large bore IV may be inserted. In cases IV lines are difficult in an emergency situation, or if the patient is obese, then a central line is taken with all sterile precautions. Meanwhile, oxygen is given through a mask at 12 liters per minute. Also, the sites of bleeding are managed by pressure dressing. Also, some people argue that if I overtransfuse to compensate for blood loss, it can also give rise to a lethal triad of coagulability, acidosis and hypothermia that may eventually cause a systemic inflammatory response. Thus, there needs to be a balance between fluid resuscitation and the patient's condition. In case a patient is bleeding torrentially, I remember the phrase like blood on the floor and 4 more. Another question people raise is how should I know that my resuscitation is adequate? My answer is apart from vitals that are stabilized, a urine output of 30 ml per hour is adequate for renal perfusion. Also, if central venous monitoring is done, then it is too also conclusive. Acid-base imbalance, well, as an orthopedic surgeon, I should admit I do not know much. However, my understanding is like common sense. Thus, respiratory alkalosis develops as a compensation to throw out excessive acid in the blood through respiration. Serum lactate, baseline and serial measurements can be done to assess severity of shock. Do I give blood in all trauma patients is one more question. Like, no, only when there is evidence of hemorrhage that is moderate to severe or low hemoglobin. Others are managed by fluids alone. Although I keep PCVs, packed cell volumes of the patient's blood type reserved. In the patients who do not seem to respond, it is important to rule out cardiopulmonary causes like cardiac tamponade or pneumothorax. Like, frequent evaluation of ABCs are vital. Whether we should warm fluids or not is also another question. Well, in my country, temperature is near equivalent to the patient's core temperature. Also, probably a warmer may be supplemented, although the cost may be an issue. But it would be quite wise to use one of the warmers for the patients to increase the temperature of the pint or the blood that is being transfused. In massive transfusions, I even use crystalloids, platelets or plasmas in addition to what I mentioned above. But in the same time, twice daily monitoring of the blood counts need to be done to prevent lethal triad of coagulability, hypothermia and acidosis. One more question is like, why coagulability happens? It signifies excessive fluid transfusion causing dilution and abnormal coagulation and also platelet aggregation. Thus, it is important to monitor daily coagulation profile. Special cases that need to be considered are old age. I won't go in those details now, but it is to understand that pre-existing comorbidity or a physiological diminished body doesn't compensate or respond to a shock situation that effectively like a young person. This is the reason why morbidity and mortality is known even with a relatively simple fracture in old patients. With this, I conclude this topic. And if you have any queries, insights or experiences, please feel free to write in the section below. If you like this video, give a thumbs up or subscribe to the channel for more of such videos.